from Dayton, Ohio. I will be presenting a case report today titled Excessive Dynamic Airway Collapse, Mimicking Severe Persistent Asthma. Excessive dynamic airway collapse, otherwise known as EDAC, describes collapse of the posterior luminal wall of the trachea, classically greater than 50% of the cross-sectional area of the airway, but without collapse of the cartilaginous rings. EDAC is commonly associated with underlying conditions including asthma, chronic obstructive pulmonary disease, and bronchiectasis. The presence of EDAC varies among literature, and it is estimated that the combined prevalence of both EDAC and tracheobronchomalacia, a similar yet distinct condition, ranges from 4 to 23% of patients undergoing bronchoscopy. A retrospective review by Park et al. Demonstrated that excessive dynamic airway collapse was in 22% of patients with history of chronic obstructive pulmonary disease or asthma undergoing bronchoscopy. However, of these patients, 73% improved with minimal to no intervention. Here, I will be presenting the case of a 48-year-old female, never smoker, who presented to the pulmonary clinic for 1 year of progressively worsening dry cough and dyspnea, which was previously attributed to severe persistent asthma. The patient was treated appropriately with inhaler therapy, which was ineffective at managing her symptoms. Pulmonary function testing was performed, which showed a fixed airway obstruction. Given these findings, the patient underwent flexible bronchoscopy, which revealed near complete occlusion of the airway, representing excessive dynamic airway collapse. The patient was started on continuous positive airway pressure. However, due to refractory symptoms, she was referred to a tertiary care center for further surgical evaluation. These pulmonary function tests show a fixed airway obstruction. Pulmonary function tests in EDAC may show subtle changes, such as diminished expiratory flow with a biphasic flow volume loop or sawtooth appearing loops. However, findings are non-diagnostic and more often they're normal. In addition, since EDAC is often associated with disorders such as asthma or chronic obstructive pulmonary disease, PFTs may reflect the pattern of the underlying disease. In these images taken during flexible bronchoscopy, we can see collapse of the posterior luminal wall of the trachea greater than 90% with deep inhalation and 50% with normal inhalation of the following locations. Figure A showing the left mainstem bronchus, B showing the right mainstem bronchus, C the proximal trachea, and D the vocal cords. EDAC is an often delayed diagnosis due to its association with other common chronic pulmonary conditions. It is an important consideration in patients whose respiratory symptoms persist after appropriate therapy for other conditions has failed. Patients are often diagnosed with EDAC months to years after the start of symptoms and after failing treatment for asthma or chronic obstructive pulmonary disease. Making an accurate diagnosis in these patients is crucial as they often require unconventional treatment, including positive pressure ventilation to maintain airway patency, or in refractory cases, airway stenting. This case highlights the frequency of delayed diagnosis, clinical features, and bronchoscopic imaging in severe EDAC. I would like to thank my mentors, Dr. Priyanka Jain and Dr. Patrick Allen, for assisting me with this case report and providing their continued support. My references are provided in this slide. Thank you for your time.